Hello, and thank you very much for having me here for this presentation. I am Dr. Veda Giri. I am an associate professor of medical oncology, cancer biology, and urology at Sidney Kimmel Cancer Center at Thomas Jefferson University. I'm also the director of the Cancer Risk Assessment and Clinical Cancer Genetics Program for the health system. I am going to be talking today about addressing disparities in prostate cancer genetic testing among African American men. We lead a robust program for genetic evaluation, genetic counseling, and testing for patients with a host of cancer concerns. And it is really important to address disparities regarding prostate cancer for the African American population and community because this is the #1 cancer in our region and nationally. And so I really appreciate the opportunity to talk about this today. I have no relevant disclosures to this presentation. I'm going to cover a few objectives in my talk. The first is giving a brief overview of the burden of prostate cancer nationally, regionally, and also in terms of disparities. And then I'm going to give a timeline of the evolution of germline testing for prostate cancer. Then switch into genetic testing and precision medicine, as this is rapidly informing ways to treat and manage prostate cancer as far as the integration of genetic testing. And then I'm going to end by talking about addressing germline prostate cancer testing for African American men and some of the efforts that we have going on in the African American community in Philadelphia. So very briefly, we know that prostate cancer is estimated to be the #1 cancer diagnosed in men in the United States, aside from skin cancer, in 2020. It is estimated that over 191,000 men will be diagnosed with prostate cancer. It is also estimated to be the second leading cause of cancer-related deaths in US men, accounting for over 33,000 deaths this year. In the Philadelphia area, prostate cancer is a major health burden. So what we see here is that Philadelphia outpaces the state of Pennsylvania and nationally in terms of incidence of prostate cancer as well as mortality from prostate cancer. So this is a really important issue in our particular region to address from our population science efforts. Importantly, the incidence and mortality rates also vary by ethnicity and race. And what we see here is actually incidence and mortality that's been pulled looking at non-Hispanic whites as well as non-Hispanic Black populations. And what we see here regarding prostate cancer is that the incidence of prostate cancer is over twice as high compared to in non-Hispanic Blacks compared to non-Hispanic whites, and also significantly higher, over twofold, in terms of mortality from prostate cancer for non-Hispanic Blacks compared to non-Hispanic whites. And this is really important because our particular catchment area in the Philadelphia region has up to 40% African American population in many of the surrounding neighborhoods. So again, a really important public health issue to address when it comes to disparities regarding genetic testing. And really what's important to help reduce this burden of incidence and mortality in particular is the germline genetic testing. And this is inherited cancer testing is what I'm referring to when talking about germline testing. This genetic testing is revolutionizing care when it comes to prostate cancer. What's important to recognize is that men with metastatic prostate cancer have been reported to have germline genetic or inherited genetic mutations in 12 to 17% of these men. And approximately 5 to 7% of men with early stage prostate cancer have been reported to carry genetic mutations. So this is a significant subset of men with prostate cancer. Germline genetic testing is increasingly impacting precision medicine, particularly in the metastatic setting. Precision management is going to be unfolding in the future in early stage disease and is also beginning to inform tailored screening approaches. And I'm going to talk about some of this in just a moment. Furthermore, it is really important to uncover genetic mutations because of the impact for hereditary cancer risk in families. This is just a brief timeline regarding the story of how we got to where we are in terms of genetic testing for prostate cancer. And this timeline shows the integration between gene discovery, testing capabilities, and precision medicine and precision management. So in terms of gene discovery, going back into the late 1990s, there was observations as far as the BRCA story goes of a higher risk of prostate cancer in BRCA positive breast cancer families, as well as higher rates of founder mutations of BRCA mutations in patients of Ashkenazi Jewish ancestry. Then there are multiple reports that showed that BRCA2 is associated with aggressive prostate cancer, and tumor sequencing studies were identified showing that there were high rates of BRCA mutations in men with metastatic prostate cancer. Then there were multiple other genes and genetic variants identified for risk for prostate cancer. Higher rates of prostate cancer were observed in families with Lynch syndrome, where there are multiple DNA mismatch repair genes associated with prostate cancer, and also lend to multiple cancer risks. HOXB13 was identified as the first hereditary prostate cancer gene in 2012. And then again, multiple DNA repair gene mutations and a host of genes were identified in the metastatic setting, as well as from clinical multi-gene testing studies. Concurrent with this scientific discovery was the complete evolution and takeoff of testing capabilities. So next generation sequencing capability became available earlier in this decade. And also at that time in 2013, the US Supreme Court ruled that naturally isolated DNA could not be patented. Upon that ruling, multiple commercial genetic testing laboratories emerged onto the scene, and therefore multiple testing available laboratories became available for testing for prostate cancer in terms of multi-gene panel testing. And then precision medicine and precision management began to take off. And so multiple phase 2 studies reported clinical activity of PARP inhibitors, which target DNA repair mutations in men with metastatic prostate cancer. There were FDA designations or indications for multiple PARP inhibitors, as well as immune checkpoint therapy with pembrolizumab. There was some emerging data of potentially more aggressive prostate cancer among men who were BRCA2 carriers in the earlier stage setting who were undergoing active surveillance. But a landmark year was actually in 2020, where there were 2 actual FDA approvals for 2 of the PARP inhibitors, rucaparib and olaparib, in the metastatic castration-resistant prostate cancer setting because of phase 3 and advanced phase 2 data that showed clinical activity and improvement in outcomes. So I'm going to be talking actually now about the precision therapy indications, because this has really become a big driver for genetic testing for prostate cancer and what this means in the African American population. So when we look at the genes that are involved in prostate cancer, we see that there are several genes that are routinely available on prostate cancer testing panels. These genes confer various risks for prostate cancer, as well as risk for aggressive disease. A key gene to keep in mind is BRCA2. BRCA2 is one of the hereditary breast ovarian cancer genes, and this particular gene is associated with strong association for prostate cancer, as well as risk for aggressive disease, and is found in higher rates in men with metastatic prostate cancer. We also see that HOXB13 does have a strong association to prostate cancer, but currently has limited data as far as aggressive disease or in terms of prevalence in metastatic prostate cancer. But multiple other DNA repair genes, such as ATM and BRCA1, the DNA mismatch repair genes, and other DNA repair genes are associated with various strengths in terms of prostate cancer susceptibility, disease aggressiveness, but have become very important in the metastatic setting as far as precision therapy indications go. So there's really a host of genes that are important to consider when thinking about prostate cancer risk aggressiveness, as well as potentially other cancer risks that might be involved. And what we're really noticing is the impact of this genetic testing on precision medicine. So multiple genes are associated in terms of thinking about metastatic treatment options or clinical trials eligibility, as you can see BRCA2 in particular. But several of these DNA repair genes are actually important in thinking about clinical trials for men with metastatic disease, as well as treatment options. So there is a rapidly emerging role of precision therapy and precision management, which really is now having genetic testing as a central aspect of care for prostate cancer treatment to reduce the burden of disease. In terms of the precision therapy and precision medicine story, there were multiple PARP inhibitors that had FDA designations based on phase 2 data. And what you can see here are just some of these trials that were reported. And here we do see improved clinical responses, particularly for BRCA2 carriers, regarding PSA50 response, overall response rates, and radiographic progression-free survival. And interestingly, what you do see here is that there is some variability in terms of responses. So BRCA2 carriers seem to have higher responses than carriers of mutations in other genes, though we do still see response rates being reported. And that this could also vary between studies. But this was really where some of the FDA designations began, was based on the earlier phase 2 studies. But as I mentioned, 2020 was a landmark year for approval of PARP inhibitors in men with metastatic disease. The first approval came for Rucaparib, which is a PARP inhibitor, and this was based on results from the Triton-2 study. This particular study was based upon men with metastatic castration-resistant prostate cancer that showed improved clinical outcomes for these men, particularly for men that had BRCA mutations. And these were men who had had prior treatment with an androgen receptor-directed therapy and a taxane-based chemotherapy. And therefore, PARP inhibitors in this setting for Rucaparib would not be given in the first-line setting for men with metastatic castration-resistant disease, but would be after a few lines of therapy and having progressed on those lines of therapy. A second PARP inhibitor was also granted FDA approval, which is Olaparib, based on the PROfound trial. And this particular trial looked at men in a very unique study design. So they had two cohorts of patients. Cohort A was for men that had BRCA1, BRCA2, or ATM mutations. And cohort B included men who had mutations in a host of other genes. They were randomized to Olaparib or physician's choice, which was typically abiraterone or enzalutamide. And what we see here is that just looking at cohort A, there was improved image-based progression-free survival for patients who were treated with Olaparib. There was also improvement in overall survival in this cohort for patients who were treated with Olaparib. And then if you combined both cohorts A and B, there was also improvement in terms of radiographic progression-free survival for patients who were treated with Olaparib. So based on this data, the FDA granted approval for Olaparib for men with metastatic castration-resistant disease who carried deleterious or suspected deleterious germline or somatic mutations in homologous recombination repair genes after they had been treated with abiraterone or enzalutamide. So again, it really opened up options for therapies for men with metastatic castration-resistant prostate cancer. Another line of therapy is immune checkpoint therapy, and this body of work is really still evolving in terms of deciding on optimal biomarkers for determining response to agents such as pembrolizumab. But in 2017, pembrolizumab received accelerated approval by the US FDA for patients who had refractory metastatic cancers who had basically demonstration of mismatch repair deficiency. So going back to a Lynch syndrome-like picture for patients that have mismatch repair deficiency or who had microsatellite instability. And this would be for patients that have progressed on prior therapies. In this particular trial, there were multiple types of cancers that were included. There was one patient with prostate cancer included in this study. And other studies are now ongoing to look at the clinical activity of pembrolizumab in metastatic castration-resistant disease after progression with combination approaches, such as with enzalutamide, irrespective of PD-1 expression or mismatch repair deficiency status. So there's more coming forth in terms of our understanding of optimal responses to pembrolizumab, but it is an option for treatment in the metastatic setting as well. In the early stage setting, as I mentioned, there was one study that looked at men who were on active surveillance. So this is for men who have early stage disease. And typically in that setting, there is the option of treatment with radical prostatectomy, radiation therapy approaches, or to really carefully follow the disease with serial biopsies and monitoring of PSA, called active surveillance. And typically, if the disease progresses while on active surveillance, then the patients are switched to definitive treatment. Here in this particular study, for men that were on active surveillance, what was reported is an upgrading of biopsies of men who were carriers of BRCA2 mutations. So when looking at combined mutation carriers, BRCA1, BRCA2, and ATM, there was a significant difference in upgrading, but really that was driven by BRCA2 status. And so this is going to be an emerging area of clinical care about whether to include BRCA2 mutation status in the early stage setting for active surveillance discussions. So I think we're going to see more coming forth in practice on this. And then as far as the role of genetic testing in prostate cancer screening, this has been an area of controversy, which many recognize in terms of overall prostate cancer screening trials. But with the recognition that BRCA2 in particular is associated with more aggressive prostate cancer, the National Comprehensive Cancer Network has included BRCA2 in prostate cancer screening guidelines in two different ways. The first is actually embedded in the hereditary breast, ovarian, and pancreatic guideline, where it is stated to recommend BRCA screening, prostate cancer screening for BRCA2 mutation carriers starting at age 40, and to consider the same for men who are BRCA1 carriers. In the prostate cancer early detection guideline, they state to consider shared decision-making for screening starting at age 40 for BRCA1 and 2 carriers, and to discuss annual versus every other year screening in this particular scenario, given that these men may have more aggressive disease. And then, so as far as who to test for, considering genetic testing for men who have prostate cancer or at risk for prostate cancer, there have been guidelines in the NCCN that have looked at this in a couple of different ways. One of these guidelines is the NCCN High Risk Assessment Breast, Ovarian, and Pancreatic Guideline, and the other guideline is the Prostate Cancer Guideline. What is common across both of those guidelines is shown here, that genetic testing is recommended for all men with metastatic prostate cancer, men of Ashkenazi Jewish ancestry, pathology that is intraductal or cribriform histology, and then very high risk or high risk disease that is based upon stage, primary Gleason pattern, as well as overall grade group and PSA level. There are some differences between these two guidelines as far as family history goes. The NCCN prostate guideline does lay out specific prostate cancer family history that would be suspicious for carrying a genetic mutation. As far as looking at other cancers in a family, there are some differences, so it can become a little bit challenging, but there are various criteria to look at as far as family history of not just prostate cancer, but other cancers in the family, such as breast cancer, ovarian cancer, colorectal cancer, pancreatic cancer, etc. And so what does all of this mean for African American men? And how can we enhance this whole field of precision medicine and access to genetic testing for this population? So what we do know is that there are disparities that exist regarding access to and understanding regarding genetic testing. So patients from ethnic minority groups have been known to participate less frequently in genetic testing, and various studies have looked at this and have uncovered that this may be due to lack of awareness or understanding of the genetic testing process, cultural beliefs or biases, financial limitations, fear of discrimination, and overall mistrust in the healthcare system. As I mentioned, this is a particular concern in the Philadelphia region, where African Americans account for up to 44% in our catchment area in many of the neighborhoods, and where the prostate cancer mortality exceeds the national average. In terms of thinking about this at a global level, we held our cancer center, Sidney Kimmel Cancer Center, hosted a consensus conference in October of 2019, which focused on implementation of germline testing for prostate cancer. And this was performed because as this field of genetic testing for prostate cancer is just taking off, we noted that there were multiple ways that genetic testing was getting implemented in the community, whether it was through referral to genetic counselors or healthcare providers ordering genetic testing on their own. There was an increasing demand for genetic counseling occurring. There was a need to help provide a framework on how to perform responsible genetic testing and informed consent for genetic testing. And then to really think about priority areas as far as what needs to be addressed in terms of making progress in terms of genetic testing for prostate cancer. And as I'm going to say in just a moment, one of the top priority areas was to address this for African American men. This was really a global conference, and I would like to thank my co-chairs, Dr. Leonard Gamella, who's the chair of the Department of Urology at Jefferson, as well as Dr. Karen Knudsen, who is the Cancer Center Director for Sidney Kimmel Cancer Center. And this was a real team-based effort, really with global representation from experts and thought leaders and patient advocates. And what you can see here is for this particular consensus conference that there was robust representation across disciplines. Urology was strongly represented, medical oncology, genetic counseling and implementation science, radiation oncology, population science, which included disparities experts, epidemiology, patients and patient advocates. This included participants from around the globe, so primarily from the United States, but also from Australia and the UK, as well as various practice settings spanning urban, suburban, rural, and other settings as well. Importantly, multiple organizations were represented. So this included the American Urologic Association, American Society of Clinical Oncology, ASTRO, American Cancer Society, the National Cancer Institute, and we needed a global perspective in terms of the impact of our recommendations, and therefore it was very important to have these organizations represented. We came together as experts across disciplines and proposed a framework for implementation of prostate cancer genetic evaluation and management. And this particular framework addresses the purpose of genetic testing, looking at this from the metastatic setting, non-metastatic setting, and for men without a diagnosis of prostate cancer, so from a screening perspective. We then moved on to talk about which of those men would meet genetic testing indications, so thinking of somewhat more simplified and unified testing criteria. Then moved on to optimal informed consent and pre-test genetic counseling strategies, which would be elements to discuss with patients before they consider having genetic testing, because we're talking about hereditary cancer risk. And this included the purpose of testing, potential to uncover hereditary cancer syndromes or multiple cancer risks, possible results, possible cost of testing, cascade testing, genetic protections in terms of genetic discrimination, types of panels that might be offered for testing. And then we moved on to look at what are the optimal genes for testing and priority genes within genetic panels for testing. And so in the metastatic setting, we talked about comprehensive panel testing, which can include up to 80 genes because of the potential for eligibility for clinical trials. We mapped out the priority genes for testing in this particular scenario. In the non-metastatic setting, we talked about potentially using what's called reflex panel testing so that doctors could order genetic testing and be able to collaborate with genetic counselors to order additional testing based upon personal and family history. BRCA2 was prioritized here in the non-metastatic setting, as well as for men who are unaffected with prostate cancer. BRCA2 was also prioritized. So BRCA2 has been prioritized across all clinical contexts as far as testing goes. We then laid out the potential impact in terms of precision treatment in the metastatic setting for the various gene mutations, impact in active surveillance discussions, and impact in terms of prostate cancer screening. And then finally, we talked about post-test disclosure strategies to refer to a genetic counselor for patients who have pathogenic or likely pathogenic mutations. Cascade testing in relatives should be done in consultation with a genetics professional, and that family cancer history is really important to glean. Now, the reason I bring all of this information up in this particular implementation framework is this is a level of complexity in terms of genetic testing for prostate cancer that needs to be imparted to various populations, and in particular needs to be delivered to African American men and their families in a way that is understandable and that they can make an informed decision for genetic testing for themselves. So therefore, this is a real area that needs to be developed with a purpose and with attention to the communities that are really at risk for prostate cancer, potentially more at risk for aggressive disease. From our consensus conference, we also laid out research priorities to advance prostate cancer genetics knowledge and practice. And the #1 area that was recommended to develop was addressing genetics of prostate cancer in diverse populations of men. This had 93% agreement within our consensus panel. And therefore, it really does support the work that I'm going to be talking about next in the community to address how do we share information about genetic testing, given that it is a very complex field, to various communities, particularly those that might be more at risk. So I'm just going to finish up the talk by talking about one of the studies that we have going on now. It's called a peer genetic study. It's a peer-based intervention for genetic evaluation for prostate cancer among African American men. And this particular study is funded by the Department of Defense, a DoD Idea Development Award. I'm the principal investigator, and my co-principal investigator is Dr. Amy Leader, also at Sidney Kimmel Cancer Center at Jefferson. And this study is being done in collaboration with City Life Clinics in Philadelphia and Me Productions in Philadelphia. The overall scope of the project is to develop and implement health education. And this is going to be focused on genetic testing for prostate cancer. The literature shows that peer health education has been used to access hard-to-reach groups with the participation of those who are of similar age, background, or interest, and really seems to be a way to engage with the community and garner interest for the topic at hand. And what's really important is our collaborations with City Life Clinics and Me Productions in this aspect. So City Life Clinics is in Philadelphia. They have multiple locations in the Philadelphia area, and they provide medical care to underserved populations. They are a key partner with us for multiple aspects of this particular study. And we're also collaborating with Me Productions in Philadelphia, which is a communications, market research, and social marketing firm. And it specializes in developing cost-effective and culturally relevant messages for hard-to-reach, low-income, and underserved audiences. And so this has become a real key partnership in terms of thinking about how to disseminate this information and to implement the study. The study itself is in 3 parts, 3 aims. The first aim is actually to conduct focus groups of African American men to get some insights about their thoughts about genetic testing and the biases or the challenges that they face when thinking about genetic testing. And then to use those results to inform an intervention. And the intervention in this particular study is a randomized trial of peer-based education versus mailed materials. So men will be, who agree to participate in the study, will be randomized to have genetic education using their peers who we will train in terms of delivering this information about genetics and genetic testing, versus receiving information in the mail and then deciding whether they would like to proceed with genetic testing. What we're looking at are various patient-reported outcomes, such as decisional conflict regarding genetic testing. Is there more conflict or less conflict between these 2 different approaches about thinking about and engaging with genetic counseling and genetic testing? And we've also built in an actual referral to our genetics program at Jefferson to be able to have genetic counseling and genetic testing as part of the study for those men that decide to choose to do that. We have conducted the focus groups as part of this grant funded project, and it was very interesting in terms of the results that we uncovered. In these focus groups, 17 African American men participated. The mean age of these men was 54 years. And interestingly, the focus group discussions and analyses revealed a few of these key themes. I'm just showing a few of them here. There were multiple themes that really were uncovered, very insightful. Some of the key or top themes that were uncovered are that men had limited understanding of prostate cancer overall, with somewhat fatalistic views toward cancer. So for example, if I'm going to get prostate cancer, what's the point of doing genetic testing or doing anything about it? Which is a really important kind of myth to address in not just the African American population, but in populations and various different cultures. Family history was recognized as an important risk factor for cancer, and therefore I think developing tools and strategies for having those discussions of family history is really important to help facilitate that for African American families and really families across the board who may have challenges about this type of discussion. But what was interesting also is that there was mixed reaction towards genetic testing. So most men were unfamiliar with it, but were in favor of learning more once they had learned more from the navigator of these focus groups. But there were some men who did not see the utility of genetic information. So as long as they understood the purpose of genetic testing and could make the decision or could consider that in a meaningful way, that is fine to think about, not sort of leaning away from genetic testing. But there has to be a clear understanding of what genetic testing can actually help with in terms of care and treatment for prostate cancer. So our focus group data really does support our randomized trial of peer-based education versus mailed information, and it's going to inform this particular messaging that we're going to be having regarding delivery of this information and implementing the study to enhance engagement of African American men in genetic evaluation. And in conclusion, genetic testing is really changing the face of prostate cancer care. As I mentioned, there is a critical need to engage African American men in genetic testing, genetic counseling, and precision medicine studies, given that these studies are showing clinical activity for various targeted therapies and that genetic testing is becoming integral to the care and treatment of men across the spectrum of their stage. So whether it's metastatic disease, all the way to men who do not have prostate cancer, but are interested in more tailored screening approaches for prostate cancer based on risk. And community-based genetic engagement is necessary to address disparities in prostate cancer precision therapy and genetic evaluation for African American men. So I would really like to thank my team and my collaborators. I'd like to thank Dr. Amy Leader, who is an associate professor in population science and is our associate director of community integration. I'd like to thank Scott Keith, who is who's an associate professor in biostatistics and is a core member of our team. This is a picture of our prostate cancer multidisciplinary team at Sidney Kimmel Cancer Center at Jefferson, where we work closely from our genetics program, along with our urology colleagues, medical oncology colleagues, and radiation oncology colleagues for integrated care of men with prostate cancer. As well as I'd like to thank our community partners, City Life Clinics and Me Productions, so that we could really have some meaningful community-based engagement regarding this field of genetic testing for prostate cancer. Thank you.